Good day. I'm Professor Chris Frey, and I'm going to talk to you about adult knee joint pathology from an orthopedic point of view. The knee joint is the largest synovial joint in the human body. We did speak about the different joints before in the previous video, so this is a synovial joint. Now in this picture you see on the left leg there is practically the bare bone, while on the right leg it's more actually a picture of what it really looks like, which is covered by ligaments and muscles and tendons. Now when we talk about stability about the knee joint, we classify stability into static and dynamic stability. Now the static stability is provided by the bone, the ligaments, the cartilage, the articulation and capsule, specifically in the knee joint, the posterior capsule. Where the secondary stability or the dynamic stability is caused by the tendons and by the muscles that are attached to that. Now let's have a look at the primary stability first. So here you would see the medial collateral ligament and the lateral collateral ligament, and I've shown this here on that side a little bit better because it's a view from the medial side on top of the knee, and then you can see this is relatively a broad ligament that comes from the proximal tibia and goes to the medial femoral condyle. The lateral collateral ligament is in comparison a very small ligament, and it does not really insert to the knee joint. It actually inserts to the head of the fibula. It still gives, however, stability to that. So these two ligaments, they lie extra-articular. So this has to do with view of healing. That means they always heal because they've got good blood supply. They're not inside the synovial joint. And when we look at another structure there that is typically for the knee joint, you see that the distal femoral condyle is a round condyle, while the tibial plateau is actually a flat surface. So it's a round on a flat surface. And so this is a different type of articulation. It is not a hinged joint. It has it's also not a ball and socket joint like the hip is. It is a joint that sort of like moves and rotates at the same time. So we call this a rollback mechanism. Now I would like to demonstrate this here on this picture. So here I pulled out one of the muscles. This is the sartorius muscle. The sartorius muscle is a very strong muscle. It goes over both joints, over the hip joints and over the knee joint. So the origin comes from the anterior superior iliac spine, and it inserts on the medial part of the tibia near the tibial tuberosity. And then it has got two actions. It flexes, abducts, and externally rotates the hip joint, and it flexes and internally rotates the knee joints. The nerve supplies the femoral nerve L2, L3, and the blood supplies from the femoral artery. So here's the knee straight, and as the knee is bent to 60 degrees and onwards, there is medial rotation of the tibia against the femoral condyles. Now we're standing behind the knee and looking from the top down onto the knee. So you see almost see-through femoral condyle, and you're looking onto the tibial plateau, and we see two structures there. These are the menisci. So they look a little bit like two horseshoes that are on either side, and they assist with contouring the knee, but also with fluid distribution or fluid movement of the synovial fluid inside. A normal knee has about 5 to 7 mils inside, but if a knee swells up for whatever reason, can be up to 100 mils of fluid inside. So it's a very large joint. So the next two structures we're going to have a look at is here. This is the anterior cruciate ligaments. The cruciate ligaments, there's an anterior and a posterior one. They both lie through inside the knee. So they're lying inside the synovial fluid. And that's the reason why they have got problems with healing, because the synovial fluid is not very conductive of healing. It has a very low oxygen tension compared to other structures in the human body. They need obviously oxygen to heal. And the anterior cruciate ligament is called the anterior cruciate ligament for the simple reason because it inserts anteriorly on the tibia. The easiest way to understand here, this is the right knee. We're looking from behind. The anterior cruciate goes like you put your hand into your pocket, while your right hand into your right pocket. So you start from the top and you go down anterior immediately. The other structure that we see here is the posterior cruciate ligament. It is a little bit broader. It stabilizes the knee, or both ligaments stabilize the knee for anterior-posterior movement. The crossing of the ligaments is extra-articular, but the ligaments are intra-articular visible. So when we have a look at the knee joint on an X-ray picture, this would be a normal knee. So on an X-ray, a bone is white and air is black. The whiter the bone is, the stronger the bone is. And you see that not all the structures are clearly visible on an X-ray. Only those that actually have X-ray density are visible, like the bone in this case. But we see, for example, here a joint line. So this would be the medial and the lateral joint line here that we can see there. And when you look at this, this looks an equal distance on both sides. The next thing that we see is the patellofemoral joint. You see the patella on top here, so this round structure. It lies on top of the distal femur condyle, and it also has a joint and articulate. So the important part is have a look at the joint space, because certain conditions, they have an influence on the height of the joint. So, like I said, equal joint height, medial and lateral. And also a similar height is on the lateral view here. So on the lateral shoot-through view, you see the tissues well aligned. You can also see the tendons a little bit, and you see the patella in front of the distal femur, and there's also a space in between. Now, another important part is the patella length. If you look at the patella length, and where it inserts on the tuberositas tibia, it actually fits 1.5 times for a normal patella inside there. So you can see, so this would be the same height, and it's just a little bit more than the same height. So if the patella is up or down, we call the up one a patella alta, and we call the down one a patella baja. So I made now this knee joint in a couple of schematic drawings here so that we understand the diseases that are coming up. So this is now a view where the knee would be bent, and we're looking from the front onto the knee. On the top you've got the patella, then you've got the femoral condyle, you've got the tibial condyle and the fibular head on the side. So this would be the left knee that we're looking at. Now everything is covered with cartilage here in blue, and you can see the cartilage is nice and fine, and there's an equal joint distance everywhere. So we have got 3 compartments on the knee that we focus on. There's a medial compartment, there is a lateral compartment, and there is a patellofemoral compartment. Now, the main conditions that I would like to start with, the first one is the disease of the cartilage. The disease of the cartilage is called osteoarthritis. Osteo is bone, arthros the joint, and itis is the word for inflammation. So like in an appendicitis, you would have the itis at the end as an inflammation. So it's just a descriptive term of this disease. Now, the other conditions we're going to go through later is the disease of the bone. So that would be avascular necrosis, where the bone collapses. And then there's the disease of the synovium. All synovium conditions give you inflammatory arthritis. The biggest group of the inflammatory arthritis would be the so-called rheumatoid arthritis. So let's go back to the osteoarthritis, the first condition to discuss. So this would be a wear and tear. So think of a tire on a car. When the tire is fresh, the car runs beautifully with the tires, but then over the years the tire becomes thinner and thinner, and it wears. And then it does not run or grip to the road that well anymore. So osteoarthritis is very similar to that. It's a wear and tear, and it starts predominantly on the medial femoral condyle. And the first thing that happens is the cartilage wears, and with the wear, you see I took part of the cartilage away here, we get narrowing of the joint space, because if this joint now loads, it actually squeezes together. The next thing that happens is that you get subchondral cysts. Now, why do these subchondral cysts happen, and what do they look like, and how can you see them on an X-ray? Think of needlework, where you just put the needles together before you put it through the sewing machine. So these needles, they have usually colored glass heads with that, and that is about the size of the cyst that you have to look for. So they're not very big, they're very small, and they're always very close to the joint. Now, how do they happen? Well, when the cartilage goes, the protection from the synovial fluid is missing, and then synovial fluid gets pushed into the bone, and that absorbs locally the bones and forms these cysts. Another important thing is these cysts are on both sides of the joint, so they are on the femoral side as well as on the tibial side. Not all cysts are on both sides of the joint, but osteoarthritis has typically cysts on both sides of the joint. And then the last thing is you get these noses. So these noses that are growing out, they're called osteophytes. Now these osteophytes, what they try to do, the bone is a reaction that wants to make the joint broader and say, I can help you by becoming broader, growing out these osteophytes. And then we can easier sort of like weight bear on these. Obviously, it doesn't work very well, but you get these osteophytes and they're often palpable. You can actually feel them when you examine a knee joint. Now, this condition does not only happen on the medial side, but predominantly that's where it starts for osteoarthritis. It also starts at the patellofemoral joint, and they have the same thing. They also have got cyst formation as well as osteophytes. Now, I've got this picture here about a gentleman who suffers severe osteoarthritis. And when we now look at what it does, I said it mainly affects the medial joint. And when the medial joint, the joint height is less, then it goes into a deformity. So here I draw the anatomical axis of the femur as well as the tibia inside, and you can see this knee is not straight anymore. So usually we have about a valgus of about 5 to 7 degrees in the knee, depending if you're male or female. And here we have got definitely a varus deformity. Now, what is a varus deformity? So that's the expression that we use for an increased distance or intercondylar distance between the one leg and the other leg. And you can measure that either in centimeters or often just refer to as how many fingers would fit into there. But this is a varus deformity, and the best way of addressing this would be obviously in degrees. So this might be 30 degrees of varus on the right leg. Okay, so these ones, that osteoarthritis gives you a deformity, and the deformity is O-shaped, and an O-shaped deformity of the knees we would call a varus deformity. Now, what do the X-rays look like? So here's an X-ray of X-rays of both knees, and they might be standing because now you can see how this joint gets squashed together, and you can see that on the lateral side or on the outside of the knee joint, the cartilage is still preserved, and you've got actually this joint line here that's still clearly visible, while on the inside there is actually everything eroded away. This thing looks very painful. Now, the next thing is patellofemoral joint in this case is also involved. Can't see that well, but there are some osteophytes that are growing out on the sides. And when we now enlarge this, I would just like to show you the narrowing of the joint space we spoke about, but these are the cysts. So maybe you can't see them, but there's like cysts. They are very small and black. They're these sort of like black holes. Remember, white is bone, and black would be less dense bone or air in general, but there's not air in the joint. It's just a cyst, and then it took away from the bone, and they are all over and they're close to the joint here. So there's another example of the cyst formation. And we've got some osteophytes there on the side. They are not always that easily visible on these view. That's why we usually take 3 views of a knee joint, an AP, that's from the front to the back, a lateral, and then also like an oblique view. And on an oblique view, you can see it very well. Now, the next thing is here, how the osteoarthritis happens in this sort of like demonstration. And you can see, first of all, you get that deformity, that varus deformity, where it's an O-shaped type of view on the knee. And when you look at it, the cartilage wears. So you see here, it's already like in red, so that looks already painful. And it wears more, and it affects the entire medial condyle primarily. And now you will see that there's also bony spurs. Also, the patellofemoral joint gets the same disease. And I just want to show you what this would look like on the femur, on the patella. So, but it is the same condition. So this is again the left knee, and you see the patella is in a patellofemoral groove where it goes inside and moves. And also this joint can be degenerative, and it starts off first with little cracks and frizzling, and then it becomes actually eroded away, and then the bone comes out. Now what gives the pain is obviously once the bone is exposed. It's like a kick against the shin that is painful. And also you see the undersurface here, and you see the osteophytes. Now how does this come forward? Well, let's have a look at the parallelogram, and I'm sure you remember that from maths. So this would be a lateral picture of the knee, a schematic drawing. So you see the patella is there in the front on the right hand side, and the quadriceps muscle is that big muscle at the top, and the tendons that are attached to this. So this big muscle has quite a strong force that pulls backwards. And then obviously the knee has to get forward, so there's a second vector that sort of like pulls upwards on this one, and this gives us a resulting vector with force and direction. And you can see this is a massive force that pushes this patella back into the femoral condyle. So there's a lot of pressure, a lot of force going through that. The second condition I would like to talk to is the avascular necrosis, or the new word is osteonecrosis, and it happens on the medial femoral condyle. And you see this here, so this has to do with the blood supply, and it forms different types of cysts, or actually not really cysts, it actually forms collapse of the bone. Now the bone gets its nutrition from a vessel, a vascular nutrition, while the cartilage gets its nutrition from the synovial joint. So the cartilage is primarily not affected. So that means the height of the joint stays intact as long as not the fully collapse has taken place. So here you see these sort of like larger structures that like formed holes because the bone cells died in this area, and now the bone collapses. And now you see that the cartilage then adapts secondary to that. So this is a view of this. It's the lateral gunnicular artery here, that is that one, and you see this is the one that is get affected with that one. It's, thank God, not very common in the knee joint, but it has a vascular component to that. And now you see here in gray that area where the bone is not well vascularized anymore, and parts of it die, and then that forms the collapse on it. Okay, and here I'm going to show you an X-ray what this looks like. So there you can see that entire bone piece has collapsed upwards on that one, and that also leads to a deformity. So this would be also a varus deformity. It's also the left knee, and it's also on the medial side, but it only affects the one side of the joint, not both sides of the joint. Okay, and the last one is the inflammatory arthritis. So we're starting off with the schematic drawing of a normal joint, and then I draw out here the synovium. Like I said, it's a very large synovial joint, and there's this inflammatory arthritis is a disease of the synovium. And the disease of the synovium, first of all, it swells, and then what it does, it's often an autoimmune disease. Auto means it attacks your own immune system, attacks your joints. There's two big groups. The one is rheumatoid factor positive, so that would be rheumatoid arthritis, and the others is a variety of diseases, Stills, Felties. There's a varieties of subgroups that have similar outcome, but they also cause a synovitis and joint destruction in the end. Now, how does this usually happen? Now, this is a very simple explanation, but they build antibodies against the joints. These joints, the antibodies, they sort of like attack the cartilage, and then, they cause erosion on the cartilage through a process that they ask other cells to come and help them because they think it's not your own body and they attack this as a foreign body. But they do this mainly on the lateral side of the joint. So you do not get a virus deformity, you get a valgus deformity. But they affect everywhere in the joint. So they affect the medial, the lateral, and the patellofemoral compartment. And then eventually they lead to these periarticular erosions. You see these indents on the side of the bone that is typical for an inflammatory arthritis. So as a general rule and commonly asked question, inflammatory arthritis comes in 3 stages. A synovitis leads to joint destruction, and that leads to deformity. Now here you got that video from the 3D Medical that explains this very well. So here you can see that this is a normal joint. Now the inflammation sets in, and you can see this already looks angry, and the synovium swells and it's thickened. It is angry on the side, and this is how big the joint is actually in the knee joint, and then it affects all these structures everywhere, but starts on the lateral side, so it gives a different type of deformity. And there you can see these periarticular erosions. See this bone is almost eroded away around close to the articular surface. These are typical features of the inflammatory arthritis. Here on the X-ray you see this. First of all, please note the valgus deformity. So there are now knock-knee type of deformity. And then you can see here that the lateral joint has collapsed, and you can also see these periarticular erosions on the side. I pointed that specifically out here on the side. And you see it's almost a tunnel view of the X-ray, because I'm sure the range of movement of this joint is severely reduced. So here is again the pictures of both ones, and you see this is a standing point of view, and you can see that they have now these knock knees, and we call those a valgus deformity. And when we put the anatomical axis inside, you see that the weight-bearing axis would be sort of like only through the lateral compartment. And now, not the knee have an intercondylar distance. Now the ankle has an intercondylar distance in fingers, or in difference, or in degrees, however you want to explain that. Good. So now for the final comment on the knee joint, we got 3 main conditions for adult or common adult knee pathology. We got the disease of the cartilage, that is called osteoarthritis. We got the disease of the bone, that's either avascular necrosis or osteonecrosis, that would be the newer word. And then we got the disease of the synovium, which is an inflammatory arthritis. So thank you. I would like to give credit